Okay, we'll go ahead and get started. I'm going to talk a little bit about the state of lung cancer, some of the things that we've done at our program in Northern Kentucky and Southeast Indiana at St. Elizabeth Healthcare. And then we'll talk about some interesting things that are on the horizon, some of which we've already heard about today. This is our team. We have had our new cancer center for about 3.5 years now, and it looks a lot like your new cancer center is going to look a little smaller, but we're very proud of this building and patients love it. And we see a lot of cancer in Northern Kentucky. This is the largest cancer center within a 250-mile radius. Our physician group is St. Elizabeth Physicians, and we serve over 400,000 patients, and our group has grown to over 800 providers now over the last 13 years or so. If we look at the leading causes of death in the United States, in 1900, they were mostly infectious diseases. Cancer was number 8. By 1940, cancer moved from the 8th to the 2nd position, and it's held that position, but it's starting to take over heart disease as the #1 killer in the country. And we've talked about that a little bit already today, how we need to prepare for that. This is a map looking at the green states here are states that already cancer has taken over heart disease as the #1 killer in the United States. We're going to be talking primarily about lung cancer. When I hear these two words today, I still can't help but get that visceral feeling. Lung cancer equals death. You know, patient has lung cancer, they're not going to see Christmas. So they're certainly not going to see 2 Christmases. And that narrative is changing. Lung cancer is historically a very aggressive cancer. It moves quickly to the stages. And historically, over 50% of lung cancer is found in stage 4, whereas we know the prognosis is much poorer. We're going to be looking at some slides that hopefully will instill a great deal of hope for patients at risk for lung cancer and with lung cancer. And hopefully when we hear these two words 5 to 10 years from now, they'll be much less impactful. If we look at cancer deaths in the United States, lung cancer kills more or as many as colon, breast, and prostate cancer combined. We used to be able to say more, but just over the last year or two, they started to be about equal when you put colon, breast, and prostate cancer together. If we look at the state of Kentucky, definitely lung cancer kills more than colon, breast, and prostate cancers combined. 2,700 people in Kentucky are estimated to die this year from lung cancer. If we look at Kansas, very similar scenario, greater than colon, breast, and prostate cancer combined. This is the national lung cancer mortality rate. The national average is about 33.6 per 100,000 population. Kentucky is clearly a bottom dweller here, 56% higher than the national rate. Kansas is a little bit better than that, but above the national average. That's the yellow bar there. We look at lung cancer incidence, similar scenario. The national average is 54.6 per 100,000 population. Kentucky, again, clearly at the bottom of this heap, 55% higher than the national average. Kansas is right about the national average for lung cancer incidence. 5-year survival rates, slowly improving. It's a lot better than it was 5 to 10 years ago, but still just more than 1/4 of patients are alive 5 years later with lung cancer. If you look at state of Kentucky, we used to be at the bottom. We're pulling off the bottom a little bit. There's 3 states below us now, but still about 1 in 5 patients are alive 5 years later with lung cancer. That data wasn't available for Kansas. Smoking, as we know, is related to lung cancer. Probably 80% or more of lung cancers are due to smoking. And the national average for adults that smoke is about 13.5%. Kentucky used to battle for the bottom position with West Virginia. Again, we're starting to pull off the bottom there. We're doing a little bit better. There's 3 states below us. These are neighbors, Indiana, Ohio, and Kansas also in the below average tier when it comes to adults that smoke at 15.6%. So there's a couple trials that put lung cancer screening on the map. The landmark trial was a national lung screening trial that was published in the New England Journal of Medicine in August of 2011. The largest study ever funded by the MCA. Over 53,000 patients across 33 centers in the United States. The sister study of that was a Nelson trial, which was published in January of 2020. And a little smaller trial, but also a very large trial, almost 16,000 patients. And these two studies together definitively proved that lung cancer screening reduces mortality from lung cancer, 20% overall reduction in NLST and a 24% overall reduction in the Nelson trial. And these percentages are actually greater than that as time went on. The NLST was just a 3-year trial. The Nelson trial is about a 5.5-year trial, and these percentages continued to improve. So this is the gizmo we use. It's a CT scanner. It's a low-dose CT scan. It uses a very low dose of radiation, 1.3 millisieverts or less. And the scan itself takes about 3 minutes. It's one of the simplest screening tests you're going to have. I tell my patients there's nothing gets put in you, up you, down you, through you, nothing gets squeezed. You're in and out of the department within 15 minutes, and it has a very high impressive yield, and we'll talk about that. So when it comes to lung cancer, as with most cancers, stage definitely matters. Historically, lung cancer in stage 4 has about a 4% 5-year survival rate if you catch it in stage 4. We're trying to shift folks up to stage 1, where you can have greater than a 90% chance of curing that lung cancer if you catch in the early stages. And for small cell cancer on the right, the percentages are even more dismal. So how are we doing? We got a very simple test. We got a very deadly deadly cancer. We got tremendous research. You'd think we'd be knocking it out of the park. Well, unfortunately, over the last 10 to 12 years or so, we've made very little progress. We've only gone up about 3% in uptake. And this study was done at the bottom right here before the USPSTF 2021 criteria came out, and the uptake rate was 6.5% for the country. If you look at the present screening rate uptake, it's about 4.5% in the country overall when you're using the USPSTF 2021 criteria. This slide was presented a couple years ago at the National Lung Cancer Roundtable, and it really puts in perspective how lung cancer screening relates to the other cancer screenings and the uptake. This is looking at cervical, breast, and colorectal cancer. Lung cancer, it's way down there at the bottom, barely getting off the ground. So I travel a lot, travel around the world, travel around the country. Everybody's heard of Kentucky Fried Chicken. That's how they know Kentucky. We're also known for some of the fastest, most beautiful racehorses in the world. And if you look at the book, 1,000 Places to See Before You Die, this is one of the chapters in there, the Kentucky Derby, and also, of course, the Bourbon Trail. And it can't be argued that Kentucky distills the best bourbon in the world. And you can't hardly go into a pub or a bar or restaurant anywhere in this world without seeing one of these bottles on the shelves. So we decided to take some of that unbridled spirit in the state of Kentucky, applied it to our work at St. Elizabeth Healthcare, and some of the work we've been doing across the state with some state-based initiatives. At St. Elizabeth, we started using the USPSTF 2021 criteria in March of 2022. So it's been just over 2 years since we adopted this. And the criteria, you have to be between 50 and 80 years of age. You have to have 20 pack years of smoking, which means you smoked a pack a day for 20 years or half a pack a day for 40 years. And you have to have smoked in the last 15 years. And that's in essence the criteria that we use for lung cancer screening. If you have those criteria, commercial insurance is required to pay for it because it has a B grade by the USPSTF. CMS, in all their wisdom, when they came out with their criteria in February 2022, they dropped it to 50 years of age, but they made the cutoff at 77 years of age. They felt like the evidence wasn't good enough in the 78 to 80-year age range to include those folks. So there's a little gap between the USPSTF and the CMS criteria, which creates some headaches for providers and patients as well. So I've kind of broken this down into 25 key components of how to build a lung cancer screening program and some of the successful parts of infrastructure for a lung cancer screening program. Have a medical director, try to find a physician champion that's going to carry the torch here. Ideally, find someone in primary care that's going to be able to help them or be the leader, and really promote it to primary care. I have a dyad partner. Winalva Zachary is her name in administration. You know, as providers, physicians, we have big ideas. We want to get things done, and we want to get things done quickly, but unfortunately, we got to deal with accountants and lawyers and resources and all these things that really slow us down. If you have somebody in administration, they help you work through some of those hurdles and barriers. We have a multidisciplinary steering committee that's made up of a lot of team members throughout our network. Of course, we have a tobacco treatment program. And I can't say enough about our navigators. We have 3 full-time lung cancer screening navigators. We also have a thoracic oncology navigator. And these ladies really are the glue for our program. They really have done a lot to instill confidence and buy-in for our providers. They walk the patient through a very scary time in their life. They communicate with the ordering provider. They communicate with the provider of referral. And they coordinate any follow-up imaging and any follow-up referrals and really walk the patient through this process. We have a thoracic tumor board that meets every Thursday morning. We have a thoracic oncology disease management team that meets once a month. And then we also use lung-RADS as our structured reporting, which most programs use now. You're required by CMS to have structured reporting, and that's a way of grading the nodules that we see through our screening program. We also have a multidisciplinary nodule review board, and this is really one of the most key critical components. It's a foundational component of our program. And we meet every Friday morning bright and early at 7 a.m. And we have a thoracic surgeon, a radiologist, a pulmonologist. Our 3 nurse navigators are there. I attend, and sometimes we have some folks from research there as well. And we'll talk a little bit more about that. It's important to get accredited. We're accredited by the ACR and the GO2 Lung Cancer Foundation. We participate in a registry with the ACR. CMS removed that requirement a couple years ago, but it's still important to be part of a registry. It's really important nowadays, especially to assimilate data and be able to benchmark and grow and improve. This is a schematic for our nodule review board. We review all lung-RADS category 4s every Friday morning. We review any suspicious and incidental nodules that come through an incidental pulmonary nodule pathway that are either marked by the radiologist. They use a code lung management. And also we have a software program called EON that combs any imaging report that includes the chest. It could be an MRI, a chest x-ray, a CAT scan, and it looks for keywords and phrases through computational linguistics. It brings them into report. The nurse navigator also brings them to the nodule review board. And we review somewhere between 30 and almost up to 50 on occasion nodules every Friday morning. These nodules are assigned a low, intermediate, suspicious, or high grade of suspicion. And then they're given one of these 5 dispositions, either follow-up imaging, a referral to a pulmonologist, a thoracic surgeon, or an oncologist, or continued follow-up if they're already seeing a specialist. Won't go into all the details here, but this is kind of how our nodule review board broke out last year. We reviewed about 1,750 nodules, and historically about 1/3 of them have been through our screening program, and 2/3 of them have been through incidental pathways. That's starting to shift a little bit as our screening has gotten better. We're now seeing about 60-40 mix. And this is how the referrals shake out. Up top are follow-up imaging, down below are the referrals, and then down below here are the grades. And we track all that month to month, year over year. We have a lot of EMR tools that have really lowered the barriers and made lung cancer screening easier for our providers. This is our health maintenance prompt. It's black or blue if the patient meets the measure and it's been satisfied. If they're overdue, it glows red, and it prompts the medical assistant and or the provider to order the test if the patient is due. This is our BPA. It's a best practice alert. This was really key in building our program in the early stages. Providers don't like BPAs. They're annoying. They're obnoxious. We would just as soon we never see another one. But sometimes when you have something like lung cancer screening that's new, it really helps to prompt the provider, hey, this patient meets lung cancer screening criteria. You can open up the smart set through the BPA, and then you can order the test, and that's the easiest, best way of doing it. We just got rid of our BPA last year. I fought it a little bit, but it really had served its purpose. We've come a long way in our lung cancer screening program, but I think in the early stages, it's well worth having. This is our smart set. If you hit the diagnosis, you get a pick list, a drop-down menu of diagnoses that qualify for lung cancer screening by CMS. There's 8 codes that you can use. But if you use one of these two codes, cigarette smoker F17.210 or personal history of tobacco use Z87.891, just about every commercial insurance, Medicaid, and Medicare will cover that test. We also encourage our providers to bill for their shared decision-making. Lung cancer screening is the only cancer screening that is mandated by CMS to do shared decision-making, but you can charge for that work. That's the flip side. And our providers get 0.52 work RVUs if they bill for the shared decision-making. It's checked by default on the baseline. You have to do it on a baseline screen. You don't have to do shared decision-making on the annual follow-up screens, but you can, and you can bill for it there too. So you open up the Smart Set, you have to indicate whether it's a baseline or an annual screen, and then it walks you through the questions that you're really obligated to ask. You have to tell the patient about the harms and benefits of lung cancer screening. You have to tell them that this may require potential follow-up testing. You have to tell them how important it is that this is an annual test. This test is to be done every year until you either age out at 80 years of age or it's been 15 years since you smoked. And then you also have to talk to them about smoking cessation if they're smoking, or emphasize the importance of continued abstinence if they have quit smoking. Once you do that, you get a diagnosis and the test that you ordered in your progress note, and then it also puts a customized progress note entry into your progress note that says this patient met the criteria, we talked to them about blah, 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 all the things you have to do for shared decision-making, and then you meet the CMS requirement. We've also configured our EMR to comb the medical record for any other CTs of the chest that have proper resolution and adequate breath hold to qualify for what would be a lung cancer screen. So if a patient's had one of these CTs of the chest, for example, if they came in the ER 3 months ago and had a CT pulmonary angiogram, they don't need a lung cancer screen. They've already been screened. And so that clock resets for another year. And so that way, of course, you keep your patients from being over-radiated, overcharged, and inconvenienced. It's something that's been really helpful. We just recently moved about a year ago to a longitudinal smoking history, and this has been really helpful for our healthcare system. We're an Epic shop, and most major EMRs have the same problem where if a patient comes in, they've been smoking a pack a day for 20 years, they've got 20 pack years, they come in and say, hey, now I'm smoking a half a pack a day. If the medical assistant provider puts that half a pack a day in the wrong discrete field, well, now they have 10 and a half pack years and they fall off the radar. This prevents that from happening. Each time you see the patient, it's a new line item and it keeps track of it in real time. So you can't go backwards in pack years. You can never go backwards in pack years, but unless somebody makes that error. This is our brochure, and these slides will be available. Tracy can certainly share all these with you. So some of these are just put in here to kind of show you some of the things that we do in our healthcare system. This is a trifold. It's available in the exam rooms and in the hallways. This is a flyer we have for our exam rooms. It basically just tells you in simple terms what the criteria are for lung cancer screening. And then we have several reports, which we'll kind of go over. This is our provider report, and this is the Hawthorne effect, which means that it was a study done many years ago that proved the obvious that behavior and performance typically improves if you know you're being watched or monitored. So this is a little healthy competition. We rank all of our sites as they are here. We have 41 primary care sites. We rank them from top to bottom, depending on what their denominator is and what their numerator is for the patients that have been screened. And we finished out last year at 46.6%, 46.8% uptake. And we finished the year before that at 44.1% uptake. So we're creeping up. And that, of course, compares favorably to the national rate of 4.5% uptake. This is the same type of list here, but this is looking at all of our providers. We have 192 primary care providers, and we rank all them as well from top to bottom. One of the most essential components of our program, and we actually got the Innovator Award from the Association of Community Cancer Centers. Last year, we presented this down in Austin, and We now have 12 outreach specialists, they're RNs that outreach to any patient that has an outstanding Cologuard, an outstanding mammogram, or an outstanding lung cancer screen that hasn't been filled. And we wait about a week. If the patient has an order for lung cancer screen, it hasn't been filled with an appointment, they get on the phone, call these folks and get them plugged in with an appointment. Usually once you got a patient with an appointment, they're going to be much more likely to show up and follow up and have this lung cancer screen done. And they scheduled about 5,000 patients in 2022. Prior to receiving that award, this is looking at 2023, a little less, but about 3,400 lung cancer screens were scheduled last year. Communicate, collaborate, educate. I can't say it enough. Anytime you get a chance to get in front of medical assistants, managers, administrators, executives, any healthcare providers, nurses, talk to them about lung cancer screening. Share the good homegrown data that you assimilate. It's one thing to talk about the NLST and the Nelson trial, but when you have really good homegrown data, and I'll share some of that with you, it really turns heads and opens eyes. We'll talk a little bit about return on investment, or ROI. That's how we were able to afford those 12 outreach specialists, because lung cancer screening is a positive net revenue endeavor. Important to have an incidental pulmonary nodule program as well. We participate in several state-based initiatives. We are members of national organizations. We participate in advocacy, and we'll talk just a little bit about patient testimonials, and of course, innovate, evolve, research, policy. Those are all important things as well. So this is how we've done. We started our program in 2013. We did 7 screens that year. We've grown pretty much exponentially almost since that time. The bottom line here is 2015, 2013 and 14 wouldn't hardly show up there, but each year as we moved along, we did more and more screens. We're on track to probably get close to 50,000 screens by the end of this year since we started our program. Last year, we did 8,888 lung cancer screens. And as of this year, the first quarter, we're at 2,505 lung cancer screens. We did 888 last month. So if that continues, we may do 10,000 lung cancer screens just this year. This is just another way of looking at this performance, the trend line, and some of the milestones that we've hit along the way. One of my favorite ones that we'll hit this month, we're 1 or 2 patients off, but we're probably going to hit it within the next few days, is 400 stage 1 lung cancers that we found since we started our program. This is 400 patients that are going to be able to see their grandchildren's wedding, to have Christmas and Thanksgiving dinner with their family. These are clearly lives that have been saved. We keep track of all the lung cancers that we found. We found about 650 lung cancers now since we started our program, and we keep track of all of these in what I call the compendium. And we track about 40 metrics for each of these lung cancers, and it generates a lot of data. This is a busy slide. I just want to point out a couple things. When you look at annual lung cancer screens versus baseline lung cancer screens, when you first start a program, they're all baseline. But as time goes on, year over year, if you can get these patients back, that's really where the rubber hits the road. You're going to be much less likely to see a stage 4 if a patient's been coming back year over year for 5, 6, 7, 8 screens. And right now, and this has continued to go up steadily, about 68% of our screens are annual screens. The other thing I want to point out is the false positive rate. It's low, it's 4.6%. And lung cancer screening kind of gets a bad rap sometimes because they talk about false discovery rate instead of false positive rate, but the false positive rate is low for lung cancer screening. The other thing that's really remarkable to point out here is the yield on this test. We're finding 1 lung cancer for every 62 screens that we do, or 1.6% of the screens that we do. If you look at individual patients that are screened, unique patients screened, we're finding one lung cancer for every 27 to 28 patients that we screen. So incredibly high yield for a very simple test and a very deadly cancer. So we do a lot of screens. This is the most important part here. Since we started our program, 62.5% have been found in stage 1. If you look at stage 1 and stage 2 combined, the early stages of lung cancer, 74% are found in the early stages of lung cancer. And this has continued over the last couple, 3 years to get significantly better each year. In 2023, we found 141 lung cancers. 101 of these were in stage 1, 72%. If we look at stage 1 and stage 2, 81% were found in the early stages last year. This is just another way of looking at that same thing. On the left side, you'll see a pie chart of all the cancers that we found since we started our program. If you look at the right side, this is what's happened so far this year in 2024. We finally saw our first stage 4 lung cancer just last week, just one so far. And the majority, I think there's maybe 36 or so lung cancers here. The majority, 29 of them are in stage 1. If you put stage 1 and stage 2 together, again, 84% so far this year were found in the early stages of lung cancer. And this is kind of looking at the why here. When you look at baseline screens, that's the red line, or I'm sorry, I think I maybe have that backwards. The baseline is actually the blue line, and the annual screens is the red line. And these lines started diverging, and they actually crossed for the first time in September of 2019. And when that happens, again, you're going to really start to improve those numbers and those percentages that you find in the early stages. And they've continued to diverge. This used to be my favorite chart to show, but now it's my second favorite. But this is really, again, part of where the rubber hits the road. This is stage migration. If you look at the green bars, this is what happens outside of a screening program. Historically, greater than 50% of lung cancer is found in stage 4. 48% in our institution, looking at over 3,000 lung cancers from 2015 to 2022. The red bars or the blue bars are what happens in a screening program. 124% more found in stage 1 than outside of a screening program. 75% less found in stage 4. So better than a mirror image. If we look at just 2022, again, you see a more substantial shift. 70% found in stage 1, 8.3% found in stage 4. So much better than a mirror image if we look at some of the later years here now. So when we look at national screening rates, we've talked about this a little bit. 4.5% is the national average. The American Lung Association puts this report out, the state of lung cancer, every November. Indiana, Ohio, our neighbors there, a little bit better than the national average. Kentucky's now number 2 in the country for lung cancer screening. We have some dismal statistics when it comes to mortality, incidence, 5-year survival rates, but we're starting to pull off the bottom because of the screening that we're doing in the state of Kentucky. Kansas, a little bit better than Ohio there at 7%, 15th in the nation, so not too bad. This is a really impressive slide. This is what's happened in the state of Kentucky. Late-stage lung cancer has been stable for decades at about 80% late-stage lung cancer, and it just really hasn't dropped until just recently here. And this isn't because of any miracles of modern medicine, it's because of screening. When you screen these folks, you're going to start seeing less and less late-stage lung cancer. And it's dropped 19% in the state of Kentucky over the last several years. So I was curious in our own healthcare system, well, what's happened with our late-stage and early-stage lung cancers? This is now my favorite slide. If you look at the orange bar, those are early-stage lung cancers. They've continued by percentage to increase. The blue bar is the late-stage lung cancers in our healthcare system, and they've continued to decrease. And these bars just crossed in 2022, just barely, but we are a little bit more than 50%, 51% stage 1 lung cancer. Now we're 56% early stage, stage 1 and stage 2 lung cancer, and 44% late stage lung cancer. So we're really starting to see a very significant divergence, 28.5% decline over the last 9 years, and that's greater than 3.5 times faster than the decline in the United States. This is another slide that kind of demonstrates the importance of adherence. If you look at the bottom, 1, 2, 3, 4, 5, 6, 7, that's how many screens that the patient has had, how many annual screens. And as time goes on, we so far have found 0 stage 4s when patients have had 6 or 7 lung cancer screens. And this is demonstrating that very effectively. So we're not spiking the ball in the end zone yet. We're not doing too bad. 46.8% screening uptake on our system. Still not really what we're seeing with breast or colon cancer screening, but we're starting to get in the ballpark. We really have a goal this year to try to exceed 50% uptake. So we start to get a little bit closer to how we're doing with breast and colon cancer screening. A little bit about ROI, I mentioned it earlier. We did a study back in 2019 where we looked at the net return on lung cancer screening. This is net revenue when you put expenses and revenues together. We generated $280.13 for every lung cancer screening we ordered. So if you look at what we did last year, 8,888 screens, that's a net revenue bottom line contribution to the hospital of $2.5 million. So you can do a lot with that kind of money when it comes to resources and building the networks and the foundations that you need for a lung cancer screening program. So just a little bit about some of the things that are going on the horizon. I mentioned Eon earlier. It's a software we use. There's several other vendors out there, but this uses computational linguistics. Again, it combs any imaging chart or any imaging that involves the chest, and it looks for keywords and phrases, and it brings those into a report if they meet certain criteria. The other thing we've talked a lot about today is biomarkers, and biomarkers can be kind of overwhelming or confusing, but if you break it down, there's really three types of biomarkers. There's biomarkers for cancer predilection. They're genetic markers or proteins or genes that indicate that you have a certain genetic predilection toward lung cancer or other cancers. There's biomarkers for cancer detection, and we'll talk about that just a little bit. And then there's biomarkers for cancer direction. If you have driver mutations or certain mutations, there are now targeted therapies that can be used, and this has made a tremendous difference in the survival of patients with lung cancer. We're working with IARC, which is International Agency for the Research on Cancer. It's a branch of the World Health Organization, on a biomarker prediction panel. It's a 21 protein panel. MCEDs, we've talked about those a little bit today, multi-cancer early detection tests. We know that we've proven that early detection reduces mortality for these 6 cancers that we screen for: cervix, lung, breast, colon, rectal, and prostate. But that's only 25% of all cancer deaths. That leaves 75% of cancer deaths on the table that we don't screen for. Some of these MCEDs can detect over 50 different cancers. And the question is, well, will this expanded testing reduce mortality for these other cancers? And that's yet to be determined. So we need to harness this data. As we generate a lot of this data, as MCEDs become more popular, we'll hopefully answer a lot of the questions that are flying around about MCEDs. And this is, in essence, what happens. If you look at this slide here, up top here is a tumor, and it sheds things into the blood. It sheds DNA, it sheds RNA, it sheds endosomes, it sheds cells themselves. And all these things can be picked up now with a blood test. It's called a liquid biopsy. So you draw a blood test, and then the technology is highly sophisticated. It can pick up infinitesimal amounts of these things that are floating around in the blood, depending on what test you're using. And then through artificial intelligence and algorithmic review of these pieces of protein or RNA or DNA, it leaves a fingerprint. You can tell that it's come from lung, or it's come from liver, or it's come from brain. There's also SCEDs, and we're working with this company out of Tel Aviv, Israel, on an SCED, which is a single cancer early detection test. And this is looking at methylated cell-free DNA that's shed by lung cancer cells that are floating around in the blood. It can be measured at very low amounts. So sensitivity somewhere in the range of 86% for stage 1. So very accurate test. Not yet FDA approved. We're expecting it might be within the next year or two. And there's some other single cancer early detection tests for lung cancer that are very close to being FDA approved. Some of them, one's from a company called Delphi, and another one's from a company called Everest. So circulating DNA can detect and indicate deadly cancers in asymptomatic people. Certainly the public's going to embrace these tests, and the word's starting to get out. There's still a lot of questions flying around about them and what the utility is actually going to be. And it hopefully will increase the screening rates for the cancers that we don't presently screen for. They are here. You can actually order, for example, Grail has a test called Gallery. It's about $985 for the test. And it's not FDA approved yet, and it's not covered by insurance. So it's an expensive test. And of course, anytime you do any of these tests, if it comes back positive, then it generates more tests. And so these expenses can certainly mount up. And how do you handle a false positive? Say you get one of these tests come back, it says, yeah, there's cancer cells floating around out there, or DNA floating around out there, and it looks like it's coming from pancreas, and you do the pancreas ultrasound or scan, and you don't see anything. Well, then what do you do? When do you repeat it? When you repeat the scan? When you repeat the MCED? So these are the questions that still have to be answered, and how are we going to deal with the potential healthcare disparity and inequity that this might create? If we look at biomarkers for cancer direction, just about 10 to 12 years ago, 50% of the cancers that were non-small cell lung cancer had an identifiable marker, an identifiable mutation. Now, 10 years later, only about 11%, probably less than that now, but do not have an identifiable marker, a genetic marker. And many of these markers you can target treatments for. The FDA has now approved at least 9 genes with driver mutations for which there's specific targeted treatments. They're most typically TKIs or tyrosine kinase inhibitors, and these can be taken by a pill once or twice a day. And dramatic response if you're lucky enough to have one of these targetable mutations or driver mutations. I won't go into that, this is a little technical, but immunotherapy, we've talked a lot about that today. That's the other frontier here, and these drugs are really beginning to become mainstream. They boost the ability of the body's immune system to fight the cancer. With lung cancer, you've heard a lot of these. They advertise these: Opdivo, Keytruda, Tecentriq, Imfinzi, Yervoy. And unfortunately, not everyone responds to immunotherapy as we saw today, but in some cases, the results can be very dramatic and have long-term control of the disease. So one of the problems that we have with these targeted therapies is that patients oftentimes, it works, but then they develop resistance. The tumors and cancers are smart. They find a way of working around the drug. So we didn't used to know that because patients never survived their treatment, but now they're surviving their treatments. The cancer is getting smarter. They're working around the drugs. So we have to use other drugs. We have to follow up with different TKIs or different immunotherapies or combinations of different drugs. And these are all ongoing parts of research that we're having to deal with. Another drug that I just wanted to mention, drug type, is what are called ADCs, or antibody drug conjugates. If you look at this blue thing in the middle here, that's a monoclonal antibody, and the green bar is a linker. And then the linker is attached to a cytotoxic chemotherapeutic agent. And these monoclonal antibodies can be specifically manufactured to go after specific tumor cells. And so it's a much more focused way of treating cancer. When these are given by infusion, they go into the blood, they attach to the cell wall, the cancer that they're going after. An endosome takes that complex in, it merges with a lysosome, and then when that happens, that cleavage occurs on that linker, and the cytotoxic payload is released into either the cytoplasm or the nucleus of the cell. And these drugs have amazing potential as well. Just a little bit about risk models. We did a study in our system called the Aspired study, looking at our experience with our first 30,000 lung screens. And surprisingly, 43% of the lung cancers in our whole system didn't meet any screening criteria that was covered by insurance. So there's a lot of folks that we're still missing. Even if we got 100% of the patients that met criteria, there's still 43% left on the table that don't. So we need a better risk prediction model. We need something better than USPSTF or the CMS criteria or the ACS guidelines. 20% of lung cancer in the United States occur in individuals without any history of smoking. Radon's a big factor. It causes probably the majority of these folks in that 20% that get lung cancer. In Asia and Africa, there's different risk factors, cooking oils and open wood burning without proper ventilation. Family history, a huge risk factor. Air pollution is a big risk factor, not only in this country, but more so in other countries across the world. Just as an example, if you look at Taiwan, over 50% of lung cancers that occur in Taiwan occur in individuals with no history of smoking. So very different biology there. One of the risk prediction models that's available now that's used in Canada and many parts of Europe is the PLCO M2012 developed by Martin Tamamagi out of Brock University in Canada. And it looks not only at these 5 criteria that we use now, age and smoking history, but it looks at 6 other criteria, including highest level of education obtained, BMI, chronic obstructive pulmonary disease, personal history of cancer, family history of cancer, and race and ethnicity. And when you put all these things together into a prediction model, on the right here, circled in blue in this Venn diagram, is what happens with the USPSTF. On the left is the circle surrounded in red, what happens if you apply the PLCO M2012. You find 20% more lung cancers if you use this risk prediction model. So as time goes on, it's probably going to be some form of AI-driven algorithm. You're going to look at all these other risk factors, some of them that are mentioned here, some of them mentioned in the other slide, and you're going to find who qualifies for lung cancer screening and at what age and what the cadence is going to be. This is an evolving science. It's far from perfect. If you add protein biomarkers, you get almost a 10% improvement in the sensitivity. So again, biomarker is going to be used at some point for lung cancer screening as well. We've been very involved in advocacy. This is from last year when we went to Capitol Hill pushing for improved lung cancer research. Lung cancer research is the lowest funding per death of any of the major cancers. Just to put in perspective, the CDMRP, which is Congressionally Directed Medical Research Program, allocates how many dollars are spent for each major cancer program. Breast cancer gets $150 million. Lung cancer gets $25 million. And it's because the breast cancer advocacy folks have done a tremendous job. They've done all this work, and it hasn't been affected so much by the stigma and the nihilism that lung cancer's affected by, but we're getting better. We have patients now that are alive 5, 10, 15, 20 years later with no evidence of disease. These folks are getting much larger in number, and their voices are getting louder. We're going to start making a difference. This March, we were in DC as well. We also work on, of course, smoking bans, some of the policy work. We've gotten involved in advocacy policy as well as research. And if you find a patient that's had a good result and is happy to tell their story, they're out there. Look for them, talk to them. It's your best marketing. These patients are delighted with the results. They're happy to tell their story. This lady down here in the bottom middle there, she was our 500th lung cancer that we discovered through our screening program, and she's just tickled to tell her story. We've gone international. We've been at the World Conference on Lung Cancer in Toronto in 2018, in Vienna, in Singapore last year. This year it's at San Diego. We've submitted an abstract, and hopefully we'll get a poster, and with any luck at all, we might even have an oral presentation. I want to say just a little bit about the White Ribbon Project. This is Heidi Naffman-Onda. Many of you all have seen white ribbons around. I have one right here. I never leave home without it. And she is a lung cancer survivor. She was diagnosed at 55 years of age with stage 3 lung cancer. Fitness instructor, never smoked a day in her life. She had a twinge in her left lower quadrant. One thing led to another. They finally got a CAT scan because one of her biomarkers for ovarian cancer was slightly elevated. She had stage 3A lung cancer. It already had spread to her mediastinum, to a carotid lymph node. And she was so frustrated by the stigma with lung cancer, the nihilism, the lack of attention lung cancer was getting. She had her husband make one of these 1 by 2 foot white ribbons out of plywood, put a label on it. They're all signed on the back by survivors, providers, caregivers, and they're in all 50 states now and 35 countries or more across the world. And her story is remarkable. We were the first cancer center in the United States to host a white ribbon build where people get together and make these ribbons, paint them, sand them, label them, sign them. And it depends on, what the legal environment is, if you can use power tools or not. When we did it here at our cancer centers, they were already cut and sanded, but patients painted them and signed them and put the labels on them. This is her scan now. She's now 5.5 years out, just had her scan a couple weeks ago, but no evidence of disease. And again, these patients are growing in number. These are the kind of stories that we're hearing more and more, that we really need to get that word out there to defeat the nihilism that lung cancer is saddled with. As an extension of that, Heidi first did this in Colorado. She's from Colorado on her hospital. We did this in Kentucky. We had these across the state of Kentucky in about 33 different institutions, white ribbons that were projected on a building for November for Lung Cancer Awareness Month. And if you want me to put you in touch with a manufacturer of these projectors and the discs, they're not real expensive, but it's pretty impactful when you see this shining on a building at night. Doing some work in Southeast Kansas. It's been really a great pleasure working with the state of Kansas. And this is a billboard that we put up for the community health centers of Southeast Kansas. And, again, people drive down the road. This is not real stigmatizing. It's not real scary. If you're over 50, did you ever smoke? Screen your lungs. Call this number. And these are the kind of messages that we need to get out there. Doing some work in rural Appalachia as well. We're going to hopefully do some of these same signs throughout Appalachia, working in the area where Kentucky and Virginia and West Virginia come together. That's the area in the country where you have the absolute worst mortality, the worst incidence, and the poorest access. And we're hoping to make a demonstrable difference there. So in summary, cancer care is entering an extraordinary era. Lung cancer has been increasingly at the forefront of many of these emerging technologies and treatments. We have to be careful that we don't tolerate progress for some and not others. And achieving equitable cancer care and outcomes is going to become increasingly difficult. So my tagline is screaming from the mountaintops. I travel a lot, I hike a lot, I don't do anything technical as far as mountain climbing goes, but I've been to the base of Mount Everest, and I've hiked the Appalachian Trail and other mountains across the world. And I always bring my white ribbon with me and have pictures and try to spread the word. So this picture in the upper right here, it's from a parable. And there was an old man, he was walking down the beach one day, and there's starfish all over the beach. And he sees this young boy throwing starfish into the water. And he looks at him and says, "Young man, what are you doing?" He says, "Well, the sun's coming up, the tide's going out, and if I don't throw these starfish in the water, they're going to die." And he looks up and down the beach, and there's tens of thousands of starfish. You can't possibly make a difference. And he reaches down and flips one out and he says, "It did for that one." So that's what we're doing. Thank you. So I'm happy to answer any questions on how we are with time. I'm going to be on a panel later, so however we want to handle that. We have time for questions. Okay.
Thank you for that presentation.
Oh, sure.
Question about if you have an idea of how many patients that a scan is ordered for, but they don't complete it. Because we struggle with that. We have only about 38% of our patients that are told they need a lung cancer screening scan will actually get one.
Yeah, I can't tell you exact numbers, but it happens a lot. I had a coronary CT scan, turned out great. But when I was there, I was talking with a CT techs, and they said, he looked at his partner and says, "What's the number one test we have that has the highest no-show rate?" And he said, "Low-dose CT lung cancer screens." And unfortunately, when we're dealing with this population, they don't tend to be our most health conscious, most compliant patients. We have to really push them, really have to nudge them, really have to work with them, use destigmatizing language, and just never take your foot off the gas. They might not get it this year, but maybe they'll get it next year, and really share with them the good outcomes and the things that you're happening and that you're discovering, and how the treatments are changing the narrative, how they're so much better than people still think lung cancer 10, 15 years ago. Why even screen for it? You're going to die anyway. but it's tough to get them in. And that's one of the reasons that we started that outreach program, because if you just give a patient a number and say, here, call this number, and we also do order up, where sometimes you can order right in the room, but that helps if you get them plugged in for an appointment. But if you've got a mechanism for following up with these patients, you can capture a lot more of those folks, because they're going to put that number on the refrigerator, their desk, or put it somewhere, or lose it, and just how it goes. A month goes by, 6 months, a year, and we're all guilty of that.
Here, thank you so much, Dr. Gieske. That's a great presentation, and congratulations for all the achievement. This is quite impressive. I was trained in Utah, and Utah has one of the lowest smoking prevalence.
Yeah.
And Utah has also have the one of the lowest cancer-related mortality in the whole United States. So we know that smoking is not only related to lung cancer, but pretty much over 20-something cancers.
Mm-hmm.
Come back to Kentucky. I would suggest maybe the incidence drop of the late stage cancer has more to do with perhaps the reduced rate of smoking. So my question is regarding the smoking cessation program. I wonder if there's anything like in place, such as the program you did here, primary care level, also as a cancer care level. Is there any stimulation, like a stimulation mechanism from CMA in place kind of promote such smoking cessation program? And if yes, there's any barrier to implement such program?
Well, reducing smoking and prevention is just as important, if not more important, than screening. And if you look at the trends for men, the incidence of lung cancer started to decline right at the last decade or two of the last century, and has continued to precipitously decline. Women's incidence of lung cancer just started to decline around the year 2000, and that's simply because of reduction in smoking. And we really, really have to work on getting folks to quit smoking, and hopefully quit vaping too, but that's another story. But there's no question that if you reduce smoking, and that was simply from policy. Again, that was no miracle modern medicine. That was policy. The Surgeon General, people going out there and really pushing for tobacco bans. And that's what caused that reduction in incidence. But it's tough. It's tough to get people to quit smoking. I've never told anybody it's easy. It's very addictive, and it's, especially when you talk about the state of Kentucky and the tobacco belt, it's so woven into the fabric of our culture. My grandfather had a tobacco farm. I worked on it a little bit. When I started practice, I had a waiting room that had a smoking section. It was surrounded by a knee wall. I mean, there's people in there smoking, smoke was billowing out. Yeah, I've been in practice a long time. And but it's just, that was accepted in the state of Kentucky. It's amazing how many, I don't know how it is in Kansas, but it's amazing how many cities and counties still in the state of Kentucky allow smoking in restaurants, bars, bowling alleys.
Could you present all these numbers as if we actually know who is eligible for lung cancer screening, and
Yeah.
yet when we actually looked at our own EHR, I think probably 60% of the current or former smokers don't have the documentation that would tell you whether they're eligible. I was impressed that you've made some inroads there. How well has that taken place? Are you still having lots of former smokers who you don't know their eligibility? And what suggestions do you have for institutions that really need to get a better handle on who's eligible?
It's a lot of work. I mean, you have to really push every button, pull every lever, and that's why I was kind of talking about getting in front of medical assistants, getting in front of managers, getting in front of nurses, talk with anybody and everybody about how important that smoking history is. It's no longer important whether you just say smoke, not smoke. You have to have those details there to see if a patient qualifies for lung cancer screening. And I never talk with anybody in our healthcare system without emphasizing how important that is. And we have a lot of folks through our physician group and managers, administration that really keep an eye on that and really push the employees and providers as well. You know, if you have somebody come in and they smell of smoke and they've got emphysema and coronary artery disease, they probably don't have 5-pack years of smoking history. You know, so you need to look at that history, talk with the patient. You know, providers can go in there and correct that history as well. So everybody needs to be accountable.
We have time for just one last question over here.
Hi, thank you. My name is Laura and I work with the Kansas Radon program.
Yeah.
And so I was curious, with radon being the second leading cause of lung cancer after smoking and the first leading cause amongst non-smokers, how common is it in the doctor's office to have, or the lung cancer screening questionnaire, to have a question about like radon testing? And is there any discussion about trying to make that more common?
Extremely important. And boy, it's a tough dial to move. We are trying to get the education out there. We actually have a flyer that we encourage providers to hang on their bulletin board. It talks about radon and the mitigation levels and how to get a free radon testing kit, et cetera. We actually entered into the smart set that I showed you that there's 3 optional questions that the ACR encourages you to ask. One is about radon exposure. Have you had a radon level that required mitigation? That's one of the questions. It's optional. We don't make our providers do that. So you know how it is. If it's not a hard stop, they probably 99% of the time blow through it, but at least it's in their face. We're trying to get that education out there. It's a lot of work. It has to be done on a local level and a state level, but so important. And that's probably how, you know, Heidi Nafmananda actually got, you know, her cancer. She worked out in her basement, which turned out it had 2 to 3 times, you know, toward the upper limits of mitigation for radon exposure. Thank you, Dr. Sure enough. Thank you.